may be caused by trauma, tumors, or drugs. To begin with, spasmodic dystonia is a focal dystonia of the vocal cord muscles. Listen to the following patients speak.
8, 7, 8, 13, 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
This next patient has the same tight, strangled quality of spasmodic dysphonia, but she improves when she whispers and does not have to activate the vocal cords.
It's a nice day.
Today is a nice day. Today is a nice day. Today is a nice day.
Whisper. Today is a nice day.
Today is a nice day. Today is a nice day.
Today is a nice day.
Today is a nice day. Today is a nice day. Today is a nice day. Today is a nice day. Don't break me.
This next patient is barely understandable because of his dystonia. The dystonia involves not only his vocal apparatus, but the facial muscles as well.
Today is a nice day in Chicago.
The final patient at rest has no obvious dystonia. When asked to speak, he develops spasmodic dysphonia and mild facial movements. However, more pronounced dystonic movements develop when he forcibly chews. Note the marked head tilt, the lateral deviation of the neck, and the activation of the platysmal and anterior chest muscles, all demonstrating that his dystonia is segmental and involves more than just an isolated area. Craniofacial dystonia is a focal dystonia that involves the muscles of the jaw and other facial muscles. Usually action-induced, the face at rest is often without dystonic signs. In this woman, as long as she is silent, she is asymptomatic other than the mild sense of jaw tightness. But when she starts to talk, the lips, tongue, and mouth develop sustained spasm that compromise the clarity of her speech.
9, 8, 7, 6, 4, 3, 2, 1.
Repeat 3 times. Today is a nice day.
Today is a nice day. Today is a nice day. Today is a nice day.
Say ma ma ma.
Ma ma ma.
Ka ka ka.
Ka ka ka.
Ta ta ta.
Ta ta ta.
La la la.
La la la.
Observe how the spasms start just as she begins to speak.
9, 8, 7, 6, 5, 4, 3, 2, 1.
This patient likewise has jaw movements, although these occur even when the patient is not speaking. At rest they are mild, and with any body activity they increase. Because of the continual jaw motion, she has eroded the enamel of her teeth. With speech, the jaw, tongue, and oral pharyngeal muscles go into tonic spasm.
Repeat the following sounds. Ma ma ma.
Ma ma ma.
Ka ka ka.
Ka ka ka.
Ta ta ta.
Ta ta ta.
La la la.
La la la.
Tapakita, tapakita, tapakita.
Tapakita, tapakita, tapakita.
At complete rest, there are still small movements which the patient can feel. This third patient has significant blepharospasm and more mild facial dystonia. This combination is occasionally called Neige syndrome, after the French neurologist of the late 19th and early 20th century. Most blepharospasm patients are women, and 3/4 develop their dystonia after the age of 50. This young woman has a family history of cramps and riding tremor, but she is the first to receive the diagnosis of dystonia.
14, 13, 12, 11, 10, 9, 8, 7.
Many patients have spasmodic dysphonia along with their cervical facial dystonia, but this woman's speech is normal. On exam, she also has prominent retrocolor. Whereas craniofacial dystonia usually is symmetric, often there is an asymmetry within the bilaterality that can suggest hemifacial spasms. This man has spasmodic dysphonia and with continued speech develops bilateral blepharospasm and facial dystonia, but it is more marked on the right. He also has a neck dystonia. As a contrast, this patient does have hemifacial spasm, and the clonic movements that are isolated to one side and the rhythmic pulling of the face and eyelid are quite characteristic of this peripherally generated movement disorder. Of course, blinking is often bilateral, but the involuntary movements themselves are isolated to one side. Truncal dystonia can cause serious gait difficulties and compromise respiratory function. It rarely occurs in isolation and is more commonly part of a generalized or segmental dystonic disorder. This businessman finds that his chest is pulled forward to the ground as he walks. With prolonged exercise, he has found that he is bent over 90 degrees. A back brace was tried, but the spasms continued unabated and the brace cut severely into his skin. The gait of patients with truncal dystonia has been called dromedary, monkey, or duck-like, depending on the more prominent feature. Like many patients with dystonia, when they walk, this patient discovered that when he walks backwards, the flexion spasms stop. Whereas this trick was effective for several months, it is no longer helpful to him. Only when the patient stops and rests can he approximate the erect posture. Even then, however, he continually feels the pulling of the abdominal muscles forward. This man has painful back arching that increases as he walks or stands. The spasms are continual, and there are also more abrupt, organized contractions superimposed that interrupt his walking. This problem began after back surgery and suggests that some forms of dystonia may relate to peripheral trauma. Like the first man, this gentleman once had a special maneuver, also known as a trick or a geste antagoniste, to abate the dystonia. By touching his right hip and left side of his neck, his truncal dystonia abated transiently. Now, however, with progress of the disease by severity and duration, he cannot find a touch or maneuver to relieve his symptoms. Even sitting is difficult because of the continued opistotonic pulling. Botulinum toxin into the involved muscles has helped both of these patients.
The term occupational dystonia is used to group together a number of dystonic disorders in which the dystonia is brought out by the postures and movements characteristic of any particular occupation. The individuals often have no dystonia and no disability during other movements, even of the same involved extremities. This individual has no particular dystonias while his hands are at rest, carrying out fine, rapid, alternating movements such as these are somewhat awkward, especially on the right. But dystonic movements markedly interrupt activities such as handwriting. Dystonic writer's cramp is perhaps the commonest and best described of the occupational dystonias. But the movement need not be associated only with handwriting, Here we have the obvious dystonic postures, which make typing extremely difficult. The marked dystonias of the right hand. This patient's occupation is clearly that of a court reporter, and again, his hands, especially on the right, demonstrate dystonic movements during his occupation. Most of the occupations which are interrupted by these dystonias share in common that the hand is being held in a specific posture and fine movements are being superimposed over this held posture.
Fundamental aspects of people's lives these days in this country, religious activities are considered perhaps the most specific, most personalized. But I'm not going to do that today. I'm just going to go through the cases because I think the comment that Judge Conti makes in the Dayton Christian School case in footnote 42 is really appropriate. And that is the constitutional adjudication involving delicate issues like including the hearing.
Occupational dystonias can cause major disability among a variety of musicians. Watch this flautist's hands as he plays. Compare the left hand, where the fingers become flattened and pull away, with the curved postures of his normal right hand. This gentleman is a drummer who again has dystonic movements when he carries out his occupation of playing the drums. While there may be some minimal dystonic postures on the right hand during these simple maneuvers in a patient without complaints, one would probably pay little attention to these. Again, rapid alternating movements are a little slow on the right side. His major problem comes in drumming. Again, note his difficulty in maintaining his posture on the right hand and holding the drumstick. The term secondary dystonia is used for those dystonias which occur in patients with known lesions of the basal ganglia. This gentleman has dystonic movements of his right hand in maintaining postures and even at times at rest. He has a small cryptic AV malformation of his left putamen. Here we see the dystonic posturing of the fingers on his right hand. Interestingly enough, in comparison with most dystonias, there is no significant torsion of the dystonic limb.
In some patients with dystonia, there are superimposed movements that may be a source of disability to themselves. This young woman has generalized dystonia with marked truncal and bilateral leg involvement. However, she is most recently bothered by the additional very rapid and disruptive body jerking movements that are seen here. These myoclonic movements in a dystonic patient are termed myoclonic dystonia, whereas the underlying dystonia has been helped with anticholinergics and focused botulinum toxin injections. The myoclonic movements have been more substantially helped with clonazepam. Note the dystonic feet, but also the superimposed very rapid and irregular jerking movements that are unpredictable in timing and amplitude. This patient was in a car accident and had a traumatic putamenal hemorrhage 3 years ago. He awoke after 4 weeks of coma with a hemiparesis. As the hemiparesis became less dense, dystonia emerged, and he was left with hemidystonia and residual upper motor neuron signs. More troublesome than either of these features, however, are the jerking myoclonic movements that have developed in the last 8 months. This type of movement disorder has been called dystonic tremor, but its very rapid and abrupt, irregular quality makes myoclonic dystonia a better denomination. Note the very marked displacement of the limbs that occurs during movement. This final patient has clear-cut generalized dystonia. Her family history includes several members with dystonia. In addition to the dystonic spasms and spasmodic dysphonia, she has many irregular jerking movements that are rapid, even lightning-like in quality. These movements dramatically abate with alcohol, a well-described characteristic of myoclonic dystonia. She too has responded very well to clonazepam. As she writes, her posture changes and she holds her hand in a typical dystonic manner and a mild tremor develops. But the brisk myoclonic jerks are not seen. She is able to hold the paper without marked movement. When she holds her hands extended, however, the brisk and unpredictable jerking becomes more evident. A second movement disorder seen with dystonia is tremor, a phenomenon that can be clinically merged with the myoclonic movements seen previously. Whereas myoclonic movements are abrupt and lightning-like, tremor, as shown here, is a to and fro oscillation that is more regular and predictable. It is often present only in certain body positions. In dystonic tremor, the tremor itself is a compensation or the result of the patient's resisting the dystonia. This patient has torticollis and a relatively regular tremor of the neck as she attempts to keep her head in the midline and resist any dystonic spasms. In most instances, this type of tremor will abate if the patient stops resisting the dystonia and lets her neck move to the maximal dystonic posture.
Gests or gestures are movements or postures which patients employ to help ameliorate the abnormal dystonic movements. They are not sufficient themselves to antagonize the movement, but their mere occurrence somehow changes the neurophysiology and alters the movement. Patients usually discover these by accident and then learn to carry them out almost unconsciously to help control the movement. They are far more common in idiopathic dystonias than they are in secondary or symptomatic dystonias. Most gestures, such as the one we just saw, involve the patient touching themselves or holding themselves. Again, the gesture itself does not prevent or antagonize the movement, but merely changes the neurophysiological background on which the movement is superimposed. Not all gestures involve movements, postures, or touching. Some can involve inanimate objects, such as this purse hanging down from the patient's head. This is how she is able to drive. This third patient also has a form of torticollis, and once again, her dystonia is controlled by an inanimate gesture. Her posture is much better when she wears this towel as a turban than when she does not. Why such objects would help improve a dystonia is clearly unknown.
Dopa-responsive dystonia is a form of generalized dystonia that begins in childhood, usually with a foot cramp and difficulty walking after exercise. This film is taken of an 11-year-old boy who is receiving carbidopa-levodopa 25-100 twice daily, and it is 4 o'clock. He shows mild dystonic posturing of his feet as he walks, but he is comfortable and has spent a full day in school, including gym class. This form of dystonia can be accompanied by bradykinesia, rigidity, and balance difficulties, and has been termed the Sagawa variant because of the diurnal fluctuation and therapeutic response to low doses of dopa. Here is the video of the same boy early in the morning and prior to his first neurologic consultation, diagnosis, and exposure to levodopa. He is barely symptomatic and walks well, although with continued exercise, he has mild cramping. His hands show minor abnormalities, but he performs his tasks of daily living well in the early morning. Here is the same boy in the late afternoon, again prior to diagnosis and levodopa. His feet have now become badly dystonic, as well as his trunk and arms. He has trouble holding a pen to do his homework because of his involuntary clenched fists. He has fallen that day in gym class. This difference between early morning function and late afternoon is typical of diurnal fluctuations, a hallmark of dopa-responsive dystonia. Once on levodopa, the dramatic improvement is sustained throughout the day. The feet hit the floor without inversion, and the boy participates in all sports activities, including the marching band. This type of dystonia has been characterized genetically and is distinct from idiopathic torsion dystonia. Dystonic movements have been seen in association with a variety of traumatic events of the central and peripheral nervous system. This woman was in a motor vehicle accident with head trauma and bilateral thalamic putamental hemorrhages, more marked on the right than the left. After awakening from coma 5 weeks later, she was quadriparetic. As the paresis improved, dystonic posturing developed, and each time she moved, she experienced involuntary hand flexion, shoulder rotation, and external deviation of her arm. The disorder is seen most prominently on the left, but is also clearly visible intermittently on the right side. Any activation of the muscles causes the involuntary dystonic posturing to supervene. The muscles cramp and are uncomfortable for her when she moves. Her feet are spontaneously inverted bilaterally at rest, and when she moves involuntarily, the toes cramp in alternating flexion and extension. The right foot is particularly painful to her. As she tries to hold both hands out in front of her, the left hand develops marked dystonic posturing. The right cramps, but she is able to control its movements. Note that there is internal rotation of the wrist, and with further arm extension, an abrupt pulling with external rotation of the entire left arm occurs. Her correction movements back to the midline are slow and deliberate because of combined weakness and dystonia. Her sensory examination is normal. When she walks, her left leg flexes and both feet have severe dystonic posturing. Dystonia also occurs with peripheral nervous system trauma to the brachial plexus and nerves. In these instances, there can be causalgia, a term coined by S. Ware Mitchell, or reflex sympathetic dystrophy. Myoclonus is a term used with imprecision and ambiguity. The best description is lightning-like muscle jerks, irregular or rhythmic, arising from the central nervous system. The first patient will be shown in a variety of activities to capture the myoclonic movements in different settings. When the patient stops speaking and tries...